Dear colleagues and friends, welcome to this second webinar of this module on neonatal gastroenterology. I am very proud to inform you that since we started to organize this webinar, we had over 18,000 participants with over 100 countries connected. And now I leave immediately the floor to Professor Noy and Professor Carnielli. Please, Professor Noy.
Thank you, Corrado. Can you all hear me okay? Excellent. So I would like to welcome all the participants to this meeting this morning. We have an excellent topic in a lecture today. Professor Nick Embleton, who I will introduce to you shortly. And I want to make sure that you are aware that we have Professor Virgilio Carnielli, who's my co-moderator and also discussant. And also we have a special guest today, Professor Bill Hay from University of Colorado, who's really one of the pioneers in neonatal nutrition and metabolism. And I've had the opportunity to work with Professor Hay over the years. And I'm just very pleased that he has agreed to be a discussant for this series of lectures. So I'd like to introduce Professor Nick Embleton to you, and I'll call him Nick. He's a consultant neonatal pediatrician and professor of neonatal medicine at Newcastle University. He helps lead a broad portfolio of translational research. And some of his studies include large-scale NIHR collaborative trials of over 5,000 infants recruited that explore the role of early feeding in preterm infants and the impact of supplemental lactoferrin and these include the ELFIN and the Sift studies. Embedded within these large pragmatic trials are microbiome and metabolome studies that collected over 25,000 samples of urine and stool from approximately 500 infants in 12 different UK hospitals. He coordinates the Newcastle preterm birth growth study, tracking the growth, cognitive, metabolic outcomes of children who were born preterm into late adolescence. He is the chief investigator of 2 large RCTs. And these include a large number of preterm infants, which evaluate HIE and the impact of DHA and choline supplementation on brain outcomes in infancy. Nick is a past member of ESPGHAN, Committee on Nutrition, and helps lead the UK-based multidisciplinary neonatal nutrition network, as well as working with colleagues in Liverpool, UK, and more recently, he's been involved in studies in Nigeria, helping to establish a neonatal nutrition network in sub-Saharan Africa. He's the clinical lead for qualitative studies exploring reproductive and or neonatal loss, which is the Butterfly Project. He's been the author of over 200 peer-reviewed publications and greater than 13,000 citations. And today he's going to talk about something that is very familiar to just about every neonatologist, very important area, and that's gastrointestinal intolerance and enteral progression. Nick, welcome.
Thanks so much, Joe, and thank you to the organizers for inviting me, Joe and Virgilio, for putting the discussion together, and Bill for joining. So I'm going to be talking mainly about feed progression in preterm infants and a little bit about GI intolerance. It'd be great to hear from any of you. You can contact us through our website. As Joe kindly pointed out, we've got a very large research program conducting large clinical trials. We're very focused on the microbiome, the metabolome. We've got active studies looking at bacteriophages in breast milk, but also IgA and HMOs. We're very focused on NEC. We have an interest in long-term metabolic outcome. Our funding comes from lots of different sources, both governmental, research council, but also some industry support as well. And the talk is really going to be focused on how to start, increase and maintain enteral feeds. but I want to first of all emphasize the importance of brain growth and nutrition. I'm going to talk a little bit about oropharyngeal colostrum, trophic feeds, speed of increases, touch on a little bit differences between the milks that might be available, but I'm not going to be discussing macronutrient or micronutrient intake numbers. There's no kind of number data in this talk at all. I'm going to give you my own personal practice, and it would be great to hear from you afterwards whether you agree with me or not. And I've got a disclosure here, which is I understand the concept of GI tolerance, but I've really no idea how to define it or operationalize it, or sometimes I'm not even sure what other people mean by the phrase. Obviously, it's not just something as simple as measuring gastric aspirates or abdominal distension. And we've got a website here, neonatalresearch.net, and so all these slides will be available on the website there if you want it. So my starting point is to emphasize to all of you that nutrition is more than simply nutrients. Of course, the nutrients, the amount of proteins, fats, micronutrients we give are important. But the second really big area that we've all become aware of over the last 10 or 20 years, the functional components, the oligosaccharides in human milk, the growth factors, the enzymes, etc. As we heard from Flavia yesterday, microbes are critical to development of the GI tract. And of course, lots of work is now focused on the role of breast milk in promoting microbial colonization. But we're also aware of the importance of the NICU environment and that's impact on the microbiome. And there is lots of active debate and research into the role of probiotics. And the fourth area of nutrition that I think is really important, of course, the technical or the socio-behavioral aspects. This might be things such as do you feed bolus or continuous, but also the importance of skin to skin, the sensory aspects of feeding, our beliefs as members of staff, behaviors, how we act towards parents, how we support mothers to breastfeed. So this is my sort of overall concept of how we can think about nutrition, and I'll use this in some of the topics that pop up later on. Now, brain growth in early life is very rapid, but unlike most primates, the rapid period of growth in humans occurs in the third trimester and immediately after discharge. Whereas for most other primates, brain growth, the rapid period finishes prior to term. And so for humans between about 24 weeks gestation and 2 years of age, we acquire about 90% of our final adult volume. Here you can see a rhinoceros with a very big head, but actually a very small brain inside this big head. Whereas in comparison, humans, the brain fills the entire cranial cavity. And on the right, you will see a scale where we compare body weight against brain weight and a logarithmic scale. And you can see that most mammals fit along this middle average line. And in comparison to that, humans have a brain that's about 10 or 20 times as big as every other mammal. And so everything about milk feeding, placental physiology is geared towards supporting brain growth in early life. Now, I told you that 90% of brain volume is acquired between 24 weeks and 2 years of age, but within this period, there are lots of different overlapping neuronal processes. Neuronal migration active throughout all 3 trimesters, apoptosis that continues into infancy, synaptogenesis that is active, very active in the 3rd trimester and early life, and myelination that may not complete until we're about 20 years of age. And now we know that many of these processes are under the control of growth factors, particularly IGF-1. And there is now accumulating evidence to show an association between nutrient intakes, particularly macronutrient intakes, and IGF-1 levels. Although, of course, there are lots of other factors that may modulate these concentrations as well. Here's a picture from our NICU, our stabilization area. And these are all the things that we think about and you talk about on the ward rounds every day. Whether you should give the baby phototherapy, whether you should put a central line in, which inotrope, what oxygen saturation, how low can the blood pressure go, how long should you give antibiotics for, should you be on CPAP or BiPAP or high flow. So NICU care is complex, but the focus tends to be on cardiorespiratory care, and there's generally a lack of focus on nutrition. Now, when I first started on my nutritional research about 20 years ago, I was pretty naive. I used to think of milk really just as a food, this food that you tipped into this great big long tube called the intestine. You suck out the fluid and the nutrients, and then you produce waste product at the end. But what we've learned in the last 20 years is that there are many, many more aspects of nutrition that are critical for healthy development, and particularly the metabolites, but also microbial interactions and immune factors. And so, as I emphasized a couple of slides back, nutrition is much more than simply nutrients, and we need to think of breast milk as being more than simply food. So I'm going to show you a few scenarios here that will be common to many of you. And these are really to exemplify how I go about starting and increasing feeds in preterm babies. So the first scenario is a 28-week gestation, fetus, estimated weight 1 kilo, there were no antenatal concerns, and the mum is admitted in spontaneous preterm labor. How at this stage should we be thinking about promoting early feeds? Well, many of you would do what I do, which is you would go and meet the parents, you would introduce yourselves, you would explain to them about prematurity, and you would ask them if they have any questions they specifically want to ask. And then I would go on to explain what happens at delivery, what are the likely short and long-term outcomes. I would also take this as an opportunity to advocate for the importance of mother's own milk. And I do this not by asking them whether they want to breastfeed, but just to pose the question to them, which is it okay for me to spend a few minutes explaining how we will help you provide your breast milk for your baby? So note what I do here, I'm not asking them whether they're going to breast milk feed or formula feed. I'm almost not giving them a chance. I'm simply saying, this is what we are going to do. We are going to help you provide your breast milk for your baby. Do you want me to talk to you a bit further? And every parent that you pose that question to says, yes, please go ahead. So the starting point of enteral feeding might be oropharyngeal colostrum. This has been widely discussed and studied over the last 5 or 10 years. And whilst we used to start off using cotton buds like this, we often now just simply get the mothers to collect the colostrum in a small 1 ml syringe like this that can be put into the babies. And here's how you could think about what this intervention is in nutritional terms by using that kind of schema that I showed you before. Of course, in 0.5 ml of breast milk, there's really very limited nutrients. But the important aspect is that the breast milk components, particularly the HMOs and growth factors, have an opportunity here to interact with pharyngeal immune tissue. But also, although I think this requires further study, it seems likely that this is going to promote a healthier oral microbiota that the baby will swallow. And in doing so, is likely to prime the lower gastrointestinal tract. But let's not again forget this kind of blue box in the bottom right-hand corner, all of these socio-technical and behavioral aspects of feeding. As an intervention, this, I think, improves maternal bonding. It allows the parents to be involved in the breastfeeding process right from the first minute. There are probably sensory aspects of taste and comfort that are also important. Now, there have been a Cochrane review looking at whether oral colostrum reduces neck sepsis, and the studies have really all been too small. There is a little bit of data here showing that use of oropharyngeal colostrum appears to reduce time to full feeds. So as I say, there are currently 6 RCTs. You're going to need really very, very large RCTs to determine effect on neck or sepsis. And some of these are underway. I have my doubts about whether we really need to do these. Personally, I think there are more important issues that we should be focusing on. And as I say, even if there is no impact on neck or sepsis, there are likely to be wider benefits on oral microbiota, but also on maternal psychology and behavior. And my own practice is to start this immediately after birth in every baby, regardless of how sick they are. I find it difficult to think of an obvious disadvantage to oropharyngeal colostrum in the babies that you admit. But perhaps this is something you can challenge me on in the discussion at the end of the session today. Now, having started the oropharyngeal question, oropharyngeal colostrum, the next question is, what about trophic feeds? What do we mean by this? Generally, we mean minimal enteral nutrition of amounts that are less than 10 or 30 mils per kilo a day. And the aim of the trophic nutrition is to prime the gut rather than provide lots of nutrients. So many people might do this for a few days. And when you ask the question, what's the evidence base for this? Well, of course, you can think of lots of different study designs. You could compare trophic feeds against complete nil by mouth, or you can compare trophic feeds against gradual increases. There are lots of different study designs, and that probably explains the heterogeneity in the published studies. And therefore, in Cochrane, there are no adequately powered trials looking at trophic feeds that are really powered to look at the impact on things like NEC and sepsis. Overall, I would say there's no evidence that trophic feeds are better than fasting or even increasing slowly, which is what we tend to do. So let's go back to our 28-week, 1 kilo baby who's now 24 hours of age. We're giving this baby Oropharyngeal Colostrum. And the question is, should we commence gastric feeds and should we increase the volume we're giving? We're mainly giving 0.5 ml into the cheek, but maybe 0.5 ml down the gastric tube. So what do we do? Again, we give positive feedback to the parents particularly, but also the nurses. And I would say something like to the mothers, you're doing really great with that colostrum. Your baby's going to really like that. We need to make sure the mum is being adequately supported, that her partner's informed that she has the necessary knowledge and equipment to express. She understands how the equipment might work in the process. And again, emphasize the importance of expression at least every 2 or 3 hours. So if we have more than 0.5 ml of colostrum, I would start to give 0.5 ml into the oral cavity, and I would put the remainder, typically another 0.5 ml, down the NG tube to start priming the gastric and the lower GI tract. Now we're going to move on another 24 hours. This baby is now 48 hours of age, and the baby is getting about 1 ml of mum's milk every 2 hours. Should I increase the feeds still further? So again, every day I'm going to talk about the positive impact of this mother's milk on this baby. I'm going to talk to her about it directly as the consultant, as the senior member of the medical team. I want this mother to know that what she's doing is really making a big difference here. And then the factors that might determine my decision as to whether to increase the volume are going to be these things. What's the presence of reversed end diastolic flow? Does the baby have a very large PDA? What do the blood gases look like? Is the baby on lots of inotrope? Is there significant abdominal distension? But also how much mother's milk is available. All of these factors might go into my decision as to whether to increase the volume of milk. Now, the question of whether you should start increasing early or late in these very high-risk babies has been studied in a large trial called the ADEPT trial that Alison Leaf published almost 10 years ago. And in this trial, 155 babies were randomized to early feeds, 179 to late feed, 400 babies, randomized. But of these, the majority received mother's own milk. So 77% of those getting early feeds as they got mother's milk, and 89 got mother's milk when they started late. And on the left here, you can see that there was clear separation. This is the early group, and this is the late group here. And this trial was of an intention to treat trial. And so there's going to be some variation in the study groups. But you can see there's clear separation. This was a large trial with over 400 babies recruited. So what did it show? It showed that babies randomized to having early feeds reached full feeds about 3 days earlier. There was no difference in the rate of NEC, no difference in the rate of cholestasis, but babies required high dependency care for 4 less days. So I think very reassuring data that you can start feeds early on day 2 and that you can increase even in the highest risk babies. These are babies with abnormal diastolic Doppler flow and were preterm. So back to this question, the baby's 48 hours of age, what am I going to do? Well, on examination, I note that the baby had absent end diastolic flow. He appears to have a small PDA. He's on a low dose of dobutamine, but the blood pressure is stable. There's no abdominal distension, but there's only 3 or 4 mils of mum's milk available every 12 hours. So what am I going to do? Probably in this situation, I'm just going to sit tight for another 24 hours. I'm going to wait for mother to provide more milk before I start increasing. Here, the baby is now 72 hours of age. Again, I'm giving positive feedback to the mother. I'm looking at the various factors. The baby is now off his dobutamine. He still has a PDA, but the mum is now making available 10 mils of milk every 3 hours. And so at this stage, I'm going to start increasing the milk feeds. So the next question is, how quickly can these feeds be increased? Well, prior to 2017, the Cochrane review had several small trials, and there was no consensus. But importantly, there were no RCTs powered for NEC or sepsis or mortality. And many of the trials didn't recruit the highest risk infants. But this is an important decision because this is a trial, or this is a question where there may be competing benefits. If you increase the feeds faster, you have less intravenous nutrition, you might have less sepsis, but potentially you might have more NEC. If you go more slowly, you have longer IV access required, you may have more sepsis, but you maybe have less NEC. So in this sort of trial or this sort of question, you have to look at long-term brain outcomes. So you need a large trial where you look at developmental outcome in infancy to balance these competing interests. And this is what the Sift trial did that we took part in, led by John Dorling and the National Perinatal Epidemiology Unit. I think this is probably one of the largest interventional trials in preterm babies with over 2,800 babies. And so in preterm babies, less than 32 weeks, we compared 30 mils a kilo a day versus 18 mils a kilo a day, i.e. a 4 to 5 day difference in the time to full feeds. And the outcome was 2 years neurodevelopmental outcome. And of course, we also looked at secondary outcomes such as NEC and sepsis. This took place in 30 hospitals. 90% of the babies received mother's milk. We recruited babies from 23 weeks up to 32, and we showed absolutely no effect on the rates of NEC, sepsis, or neurodevelopment at 2 years of age. And even when you break it down and you just look at the babies at 23 or 24 weeks, there is no difference in outcome between an intention to feed more quickly or more slowly. And this is then what the Cochrane meta-analysis looks like. You can see that the Sift study in the large blue square dominates the meta-analysis. There is no difference in the rate of NEC or mortality. There is a suggestion that sepsis might be a little bit lower in babies on faster feed. And importantly, when you look at the Cochrane, you can see that the Sift trial contributes around about 70 to 80% of all infants. So what are the implications for practice? This is clearly a very important trial, although it showed there was no overall difference between the two groups. What you can say, based on the Sift data, is that an average of day 3 or 4 of life in a baby tolerating milk, because that was an entry criteria for the trial, it is okay to aim to increase the feeds at 30 mils a kilo a day. However, important to recognize that the benefits or risks may differ if you start feeds very early and try and increase them very quickly from the beginning. It also says to us that in these neonatal units, there was no extra rate of sepsis from a 4 or 5 day prolonged extra duration of PN. And so to me, this says it's okay not to push the increases every day if you're not entirely happy with the baby. However, in the babies tolerating the milk, faster increases definitely do not increase the rate of NEC. And going more slowly in the babies who are tolerating the milk means they require IV access, more PN, longer NICU stay. Remember, this was a trial of intention. Many of the smallest babies took much longer to reach full enteral feeds. And the context matters. The risks and benefits may be different in other settings. So this was conducted in the UK with a very high level of NICU resources. The impact of fast or slow feeds may be different in resource poor settings. So let's go back to this baby who's now between 3 and 4 days of age, is on mum's milk 2 mils every 2 hours. Should I increase at 18 or 30, and what sort of factors might affect my decision? Well, again, I'm going to examine the baby. He's still got a small PDA, but I've got lots of mum's milk available. And I'm going to pick a median value here. I'm going to choose to go up at 24 mils a kilo a day, because this is a 28-weeker, 1 kilo, who's moderately stable. I think if the baby was more mature than 28 weeks, I would definitely go a bit faster. If the baby was a bit smaller or had other risk factors, I might go a bit more slowly. What about continuous or bolus feeds? Does this make a difference? Well, bolus feeds, of course, could be 1 hourly, 2 hourly, 3 or 4 hourly. Of course, the fetus tends to bolus feed, but it does so every 10 or 20 minutes with a whole series of gulping and then quiescence for a little bit longer. Overall, if you look at the basic science studies, bolus in comparison to continuous results in better GI motility, better gallbladder contraction. It does cause small changes to gut blood flow, but it may also result in less fat loss, which might be important when you're using mother's milk in plastic syringes and tubes. So, as I say, it's up to you to choose what you do. We tend to use continuous at the start and then move to bolus. What about nasogastric or orogastric feeding tubes? Well, nasogastric tubes are easier to secure. They move around less. Perhaps they cause a little bit less apnea. They may result in lower rates of oral hypersensitivity because you're not fiddling with the mouth, but they do increase upper airways obstruction. Whereas orogastric tubes prevent less airway obstruction, but there's more movement. They're easy to dislodge, and they may potentially interfere with oral breastfeeding. And I would say, again, in this situation, do what works for your NICU staff resources and your babies. What do we tend to do? Well, in our bigger babies without respiratory problems, we tend to use nasogastric tubes. We tend to use nasogastric when they're learning to breastfeed, and if we're particularly concerned about oral hypersensitivity. But we tend to use orogastric tubes in the smaller babies in the first few days and weeks. Again, my advice here is listen to your nurses. They are the experts here. So when we're starting feeds, a big question that crops up is what milk should we use? Donor milk is now very widespread across the world. The world leaders are probably Brazil, but there are several hundred milk banks now across Europe. Overall, the Cochrane meta-analysis suggests there's less NEC, but all of the RCTs are underpowered. There's no obvious impact on long-term brain development. There's no clear effect on breastfeeding duration. It's clearly more expensive than formula milk, and therefore you might choose to use the money on something else. Donor milk has lower nutrient density than mother's own milk, and growth is often a bit more slow. And despite all of this, there's really no consensus then on which babies might benefit most. Clearly, the most immature babies have most to gain from the reduction of NEC, but they also have most to lose in terms of small growth. And there's no consensus on how long you should feed it for. So should you just give it until the babies are on full feeds, or should you give it until discharge? And the data overall suggests that where mum's milk usage is very high, and this came from the Dutch study, there may be minimal benefit in terms of disease reduction. However, even if there's no impact to NEC or sepsis, remember that there may be impacts on staff belief or maternal psychology. So this is the Cochrane meta-analysis of donor milk. You can see that weight gain is a bit slower in the donor milk group compared to the formula milk group. But there does appear to be this lower rate of NEC, or say higher rate of NEC with formula, that is significant, but potentially not quite significant where it's used as to make up any shortfall. So say here, this is where donor milk is used as the sole diet. These studies are all pretty old, apart from the Cristofalo study. So it really does seem to be, if you have no mum's milk available at all, donor milk definitely seems to be much better than formula. But where you use it to make up any shortfall, the effects are only just a borderline significant. But I think many of us feel that there is a benefit to using donor milk. So the meta-analysis isn't great, but it's the best evidence we have. None of the trials are powered on NEC. Importantly, it doesn't seem to reduce mortality, and the benefits are less strong. So my own feeling is that the low rate of NEC is probably true, but no strong evidence that it improves longer-term brain outcomes. And just touching then on breast milk, there are lots of reasons why starting milk feeds with mother's milk might be beneficial. There might be something about the nutrient quality or quantity or the functional components. And what about donor milk? So this is a slide adapted from Paula Meyer's study showing that colostrum and preterm mother's milk have much higher levels of bioactive proteins compared to donor milk, much higher levels of growth factors, but also more positive microbes, because of course donor milk is sterilized. And we could also think of differences in macronutrients, different types of protein whey, and then also higher levels of hormones, enzymes. But importantly, it does appear that human milk oligosaccharides, which are highly individual, are better protected in colostrum, but you still get decent levels in donor milk, and that might explain some of the benefits. And again, just going back to the schema I showed you at the start, here's a way of thinking of it. So in terms of donor human milk, the nutrient quality is clearly much greater, but it's of lower density compared to mother's milk or formula. Some of the components may be affected by pasteurization, so it may not have the same functional benefits. It's pasteurized like mum, so it won't do the same thing to your gut microbiome that mother's own milk does, but it may also have these wider benefits. It may impact on maternal belief and staff behaviors that may overall improve rates of mother's own milk. So if you haven't got mother's milk and you haven't got access to donor milk, which formula should you choose? You'll be aware that there are preterm formulas with high levels of protein and energy, or term formulas. And the question that often crops up is, should we use a whole protein or a hydrolyzed milk or even an elemental amino acid formula? So I'm just going to touch on what we mean by hydrolyzed, explain that there is a difference between extensive and partial, but also talk about elemental. When we talk about elemental, here you find that the nitrogen all comes as amino acids. There are no peptides or proteins in an elemental formula. And so on the left here, you remember from your biochemistry days, the protein made up of a whole complex chain of amino acids. The amino acids have their own unique structures with different side chains to give them different properties. And so what we eat obviously is protein, but when we're doing our studies, we tend to be measuring nitrogen. Certainly we're measuring nitrogen in the urine, but really what the human body needs is amino acids. We need essential amino acids, non-essential, but also in neonatal, preterm neonates, lots of your non-essential amino acids may be conditionally essential. And as I say, I'm not going to go through these in detail, but it's important to recognize that it's the amino acids rather than the proteins we need. And so proteins are made of these great big long strings of amino acids with primary, secondary, tertiary, and quaternary structures. And you need these quaternary structures for them to be functionally active. And so hemoglobin is a great example of this. And when you denature protein, you lose these structures. So why is this relevant to starting milk? Well, actually, human milk is not just a whole protein milk. If you do proteomic analysis of human milk, you'll find lots of different protein fragments there. And so proteolysis actually does start in the mammary gland to an extent. And proteases will initiate protein digestion, but we have therefore in them anti-proteases to protect some of these functional proteins. So for example, that's what antitrypsin is. It's there to stop some of this trypsin-like activity. And probably these proteases are also present in saliva. So here again, when we eat the protein at the start, it goes into the acid. Now, importantly, in preterm babies, the acid in the stomach isn't quite as low as you might find in term babies. And as the protein passes through the tract, we find microbial interactions. Again, this links in with what Flavia was saying yesterday. Basically, your protein is slowly denatured, and this is what nature intended. This is what human babies want to actually have. So why is it that we use hydrolyzed milks? Actually, to me, it's not obvious why many formulas are hydrolyzed. I think people still believe that they may reduce allergy or they might improve digestion, but I haven't really ever seen any great studies of this. So people do use hydrolyzed milks, particularly after NEC, but note that they do have higher osmolality, and there may be lots of other differences. And lots of these hydrolyzed or elemental milks are designed for term infants and not preterm infants. Say people have been using these hydrolyzed milks, but to me, there's no real good evidence that cow's milk allergy is a common issue on most NICUs. Lots of the RCTs don't suggest this is an effective strategy. But importantly, the industrial processes that make these hydrolyzed milks create protein fragments that are very different to those that would normally appear in nature. And the end product will differ between different companies. And it may be that if you artificially hydrolyze these milks, you actually prevent the formation of certain key bioactive peptides that would normally be created within the gut. But you also might create bioactive peptides that don't normally exist, and you certainly increase free amino acid levels. There's a small Cochrane review on this where we looked at the difference between using hydrolyzed or whole milks. And again, most of these studies are really too small to come to any firm conclusions, but overall, no obvious differences. So is this a concern? Is it fine to use hydrolyzed or elemental milks? Well, you do see differences in plasma amino acid profiles, and as I say, this in part reflects the fact that nitrogen retention is less efficient if you're using hydrolyzed milks. But there's very little data on these other aspects, and these might be important. Actually, these amino acids absorb much more rapidly from the gastrointestinal tract, and that may impact on IGF-1 levels. It may impact on maturation of the GI tract. Maybe you need peptides for your GI tract to develop normally. So elemental milks might not be such a good idea. You probably need whole protein for your pancreas to mature properly. And there may be a whole range of impacts on the microbiome or sensory effects. And hydrolyzed milks are generally more expensive as well. So no evidence that routine using hydrolyzed or elemental milks to improve speed of feed increases or decrease GI intolerance is beneficial. No evidence that it reduces your risks of NEC, and no differences between the different milks available. And therefore my bias is, if you are using formula to start feeds, I don't think it actually matters what type of formula you use. My own personal practice really is to spend your time focusing efforts to support the mothers to provide their own milk. And again, you could use the schema I came up with before to think about different ways that you could consider whether using hydrolyzed milks in the situation might be beneficial or harmful. So let's just go back to our baby. This baby is now 14 days of age, is still getting a bit of oropharyngeal colostrum for mouth care. He's on a good amount of mother's milk, 175 mils a kilo a day. He's in CPAP, is in air, and is on a good amount of milk. And the OG tube needed replacing. And when it got replaced, the nurse presented me with 6 mils of green aspirate. And the question is, what should I do? Well, my starting point would be to speak with the bedside nurse. Have there been any other changes in the vital signs? Has this baby got a large PDA? I would examine the baby, listen for a large PDA. Is the temperature stable? How would I have a look at the abdomen? Noting that a loopy abdomen is actually pretty common in these babies. Has the baby been stooling? Does the stool itself look normal? And then if all of that looks all right, often my decision at that stage would be simply to replace the aspirate and keep feeding the baby, and recommend not routinely checking the gastric aspirates. So the trials that are available to date show there is no benefit to routinely checking gastric aspirates in otherwise well babies. Many of you will note that a volume of between 5 or even up to 10 mils a kilo can be quite common. The volume or color of this is not predictive of NEC. Overall, in the Cochrane, there are a few high-quality trials, but we do know that routine checking seems to delay time to full feeds and increase days on PN, and no evidence that reduces your risk of NEC. So as I say, what I've tried to do in the talk today is emphasize a holistic approach to nutrition, to starting milk feeds and to your definitions of GI tolerance. Mother's breast milk is key. We need to support them. We need to promote breast milk. We need to work with advocacy organizations to improve it. Don't forget all of the technical socio-behavioral aspects that are important in establishing feeds, the importance of kangaroo care, the importance of a quiet and warm environment, the need for all our equipment and good infection control, the need to have good guidelines, audits, policies. We need to give the mothers food and drink if we want them to produce breast milk. We need to train and educate our peers. But importantly, all of you involved in the session today should recognize your role as potential leaders, and you need to role model these behaviors, particularly the importance of talking about breast milk with the mothers. But I would say that if you want to make a difference, you can. All of us, I think, could go out to our neonatal unit today and improve some aspect if we really wanted to make a difference. And we know that over time, breast milk, let's say better nutrition, has been key to improve survival of lots of the babies we look after. But in turn, as more babies survive, nutritional needs become more important and complex. And I think Tom will talk about some of this in the session tomorrow. So as I say, breast milk really is the most important and cost-effective intervention for nutrition that we have available. And why is that? Well, here is a schematic really looking at the different components of breast milk. And what you see here are 75 components in formula milk that are all separately analyzed, but then popping up here in color are all the additional factors that appear in breast milk that will not appear in formula. And these may be compounds like creatine and ureas, but a whole range of amino acids, a whole range of long-chain fatty acids that you won't find in current formula, lots of steroid components or nucleotides, lots of different growth factors, enzymes, cholecystokinin, prolactin, oxytocin, all of these things probably are doing something important. Lots of immune elements, lots of interleukins and cytokines and other growth factors. And so here are 300 different reasons why mother's milk might be more effective than formula. So summary, nutrition is more than nutrients. Use Oropharyngeal Colostrum from day 0. Good reasons to use it even though there are no large RCTs. Your feeding rates can go up between 18 and 30 when the baby is tolerating milk and when there's sufficient mother's own milk, but importantly, prioritize mum's milk at all stages. No real difference between nasogastric and orogastric or bolus and continuous, no strong data there. Do what works in your unit. Use donor milk if you have it available. And then, as I say, hydrolyzed or elemental formula, although this is widely promoted, I really don't see any evidence in the studies that suggests we should be using this routinely in the babies on the neonatal unit. And finally, just to say, a copy of the slides is available on our research website there if you want to use it. And I'm going to finish there and open it up to any questions. Thank you.
Thank you very much, Nick, for this excellent presentation. We do have some questions that were raised by some of the participants, but I'd like to open the floor to the co-moderator and Bill, and also Flavia, I see, has joined us. And maybe they might have some comments or questions. I also have some, but let's open it to them first.
Yeah. I have a small question. Well, question is a comment. And absolutely, I share Nick's idea and Nick's position about the amino acid formula or hydrolyzed formula, because the use of this formula was very popular like 20 years ago, because it was supposed to improve motility. And because Walter Miach made this study, on gastric transit time, we repeat the study with the electrogastrography in preterm newborn, and we didn't find any difference. I have to be sincere, I was young and I was enthusiastic of that it should be something that could help us in the feeding intolerance problem, but was not. And I have to be sincere, I'm now much more skeptic about this use because of all that nutrition deficiency that they can bring, and because there's something more than a protein into the milk. Yeah, definitely I'm agree with Nick.
Yeah, thanks, Flavia. I mean, it's really just a question that crops up a lot of the time when people ask me, like, if I haven't got donor milk, should I use a hydrolyzed milk? And I think there's just no data to support that. Walter Miach's study did show faster motility. I have to say, I'm not sure necessarily whether that's a beneficial outcome. I mean, we know that absorption, malabsorption are important challenges in preterm babies. If the stuff rushes through your GI tract much more quickly, maybe your percentage absorption rates go down. So I agree that there may be some effect in the previous trials of motility. I still struggle to see that there's a place for routine use of hydrolyzed or elemental milks. In babies who've had neck surgery, very shortcuts, I think that's a different question. But certainly routinely, I don't see any need to use anything other than whole milks as the data currently stand.
Virgilio, Bill, comments, questions?
Well, I have for probably, thank you, Nick. Presentation was excellent. Could you expand a bit, or at least share with you what you consider risk factor for nutrition in terms of sickness or so? In the first slide, you listed, a series of intervention or drugs or so, which you would sort of consider putting, nutrition a bit of the risk or so. To me, this is an important issue because I think feeding practices may vary from center to centers depending on the perception of a risk of a condition that implies a risk for nutrition. If you would sort of spend a couple of minutes and telling what in your experience is or what is you share with your colleagues in terms of being more aggressive or more prudent in this respect?
There's no doubt if you've got a 24-weeker requiring adrenaline, vasoconstrictive inotropes, lots of fluid, horrible gases, nobody's going to be rushing to try and get that baby to tolerate milk. I mean, the intestine just won't have enough blood supply for it to absorb milk. You can put it in there, but it's not going to be effective. So in these very sick babies, we simply focus on making sure the babies get a bit of oropharyngeal colostrum, and that we work with the mothers to explain that even though that baby can't tolerate milk, it's important that she learns to express her milk and gets her supply up. Because if in those first few days, because the milk isn't going to the baby, she thinks that she doesn't have to express, it's very difficult to establish lactation after that. So I think in the sickest babies, we're all agreed there's no benefit to try and forcing lots of milk into these babies. But I think more often the situation's the other way around. More often we're faced with, 1 kilo, even 600 gram babies who are actually incredibly well. They're in low amounts of ventilator, they're in low amounts of oxygen, they really don't need much inotrope or anything, and their gases are okay. And you see that people find every excuse under the sun to avoid feeding these babies because they're just scared that they might be the one to give that baby neck. But actually, I think, the accumulated data today suggests that if at 2 or 3 days of age, and particularly if you've got mum's milk there, and the babies are, as I say, otherwise appearing healthy, it's absolutely fine to start milk and increase it. And I think the way to get around that is to have unit guidelines. I think individual clinicians tend to feel responsible if they make a decision to start and increase the feeds. They think, oh my God, if he gets neck, then it's all my fault. And actually, so the way to get around that is to say, look, as a unit, this is how we're going to do it. We are all agreed that in this situation, the baby's going to start on milk and we're going to increase it. And so it doesn't become the responsibility of an individual. So I think more often the challenge isn't in the sickest babies. We know the sickest babies are not going to be absorbing it. I think it's more in the well babies who are just deprived because people are kind of scared to make that decision, or every time the baby gets a green aspirate, they want to stop, or every time the baby gets a distended abdomen, they want to stop. But all the studies suggest that is of no benefit, and ultimately is probably harmful because it simply increases the time that you require an IV line for parenteral nutrition.
Right. Yeah, I absolutely agree. We sometimes we discuss about reverse blood flow in the abdominal aorta also, which is becoming the awareness of this reverse flow. It's increasing because many doctors play with ultrasound and so. Is there reason concern in an otherwise well baby with perhaps a hemodynamically significant PDA? Is there a concern for you? Or
I don't think we know. I don't. To me, of course, poor blood flow to the gut has to be a risk factor for neck. But to me, this still feels like people looking for more and more reasons not to feed the baby. most of the bad neck we see late on tends just to come out of the blue. It doesn't happen in the first few days of life when you imagine blood flow is most critical. So the neck that you see at 20, 30 days of age, that's not related to blood flow unless the baby's become unwell for another reason. And in early life, none of us really understand why these babies are getting neck. Undoubtedly, blood flow to the epithelium might be there somewhere. But, we've all looked after hundreds of, 500-gram babies who presumably have, suffered a degree of growth retardation in utero. They may have got ducts and they seem to tolerate feed. So I'm not saying we should ignore it. I personally don't go looking for it because I don't find it helpful in my decision making as it is.
Thank you.
Bill, any comments?
Thank you, Nick. As always, you make me think about all sorts of things related to nutrition. And as Joe already pointed out, I have quite a historical perspective on this. Back in the ancient days in the last century, babies simply weren't fed, and we've learned to feed them now. And so now you're at the stage of refining the best way to feed them. I have a couple of questions. One is simply that you totally avoided the elephant in the room, donor milk, and the need for fortifiers. You left fortifier out of your talk entirely. And finally, at your very last slide, as well as your first slide, you said you really didn't know what feeding intolerance or not, or what tolerance or intolerance might mean. And so you said, feed the baby as early and as fast as possible, as long as tolerated. How do you know if the baby is tolerating?
Yeah.
Those are just a couple. I see we have up to the 16 questions. So those are the only ones I'll ask.
It's a catch-22. I left fortifiers out because I was just trying to concentrate on the first few days, and I tend not to fortify until the babies are on full feeds. There's data, of course, to show that you can start earlier, and that's probably fine. But I won't get into the fortifier debate today. And you're absolutely right. I mean, feed tolerance, and if the baby is tolerating it, it's a classic catch-22. I don't know how to define it. All I'm trying to do, I think, is make the point that just because you retrieve a gastric aspirate of 5 or 10 mils, or just because the baby has abdominal distension, those to me are not really signs of feed intolerance. I mean, clearly gastric emptying is affected when the gut is disturbed in some way. But feed intolerance is talked about as if there is some sort of strict definition of it. And I really don't know what the definition is. I mean, clearly we accept the concept that there are some babies in whom motility, digestion is awry, and they're not able to, quotes, tolerate the milk you're giving them. But I don't think it's an easy term to define.
Would you accept vomiting, emesis, as a feeding intolerance?
I don't tend to see it like that. I mean, I see an awful lot of babies, if you do rounds, who seem to have a little bit of milk in their mouth occasionally, and the nurses wipe it up and we just continue. I mean, I don't see milk in the mouth, vomiting, emesis, whatever you call it, as an important sign of tolerance in the majority of the preterm babies that we look after. I think it's a normal feature in babies with poor gastroesophageal junction and an NG tube that stops it from closing. I think it's inevitable that most babies are going to have some milk appearing in their mouth from time to time.
Very good.
Yeah.
So go ahead.
No, I think we have some question, and I think from the audience, it would be nice to, even to give short answers to this question. So I think we have because Nick gave us such a practical talk, or so perhaps.
Do you want to just start at the beginning and work through?
Yeah, probably.
Okay.
I would like to pick up the CMV question, the fortifier, I guess you answer. But probably in the interest of time, since you have them in your screen, on your screen, you could sort of quickly go through.
I agree. Okay, oropharyngeal swab. As I say, we don't use swabs now. We use a 1 ml syringe. We started on hour 0 if we can. And I would keep on doing that throughout the duration of the baby's stay on the neonatal unit. The baby needs something in its mouth for sensory aspects, taste, probably the microbiome. So I think the babies should be offered mouth care using breast milk throughout the entire duration of their stay. Maintaining enteral feeding for 72 hours, it depends on the availability of mum's milk and how well the baby is. If I've got a very big baby, say a 1.2 kilo baby with lots of mum's milk, I might start increasing at 48 hours of life. If I've got a very tiny baby, and particularly if I haven't got mum's milk available, I might wait a little bit longer. Continuous feeds, yeah, we give the continuous feeds over 24 hours. There's a major risk of losing fat and potentially other fat-soluble nutrients such as vitamins if you use continuous feeding. So you do need to gently tilt your syringe and have the tube coming off at the highest point to make sure you don't use it. And I would say once you've got the baby onto full feeds using continuously, at that stage, I would move the baby over to bolus. But we give it for 24 hours without any break. We don't pasteurize mum's breast milk for the purpose of CMV. We recognize this might be an issue in some babies, but you have to offset that against the downsides of inactivating monodysfunctional components of breast milk. So what you might gain by inactivating the CMV, you might lose by inactivating the functional components. I think this is going to be a question that is going to be very country specific. In countries where you have very high rates of active CMV in the mothers, these may be places where they choose to pasteurize, but we don't do it in the UK. We don't see lots of babies, but we do see the occasional baby. I think it's a very important topic, and I don't think anybody anybody knows the answer yet. Do I use fortifier, human or bovine? We use a bovine fortifier at present. There are lots of studies ongoing, and there are different products available. But my feeling at the minute is that the cost of these human-derived fortifiers have not been shown in the setting that I work in to be clearly beneficial. But I expect we're going to see many more trials over the next 1 or 2 days. Study question here about 26 weekers with greenish residues. I would just ignore them. It sounds normal. I wouldn't stop the feeds for that. How many days do I expect to reach birth weight if only on mum's milk for a 28-week baby? I don't know. My focus is on getting as much mum's milk into that baby as I possibly can. That's the one thing I know will make a difference to this baby. So of course we should be looking at growth charts, we should be looking at weight gain, but we improve the baby's long-term health by maximizing the amount of mum's milk we get into the baby. I don't recommend prokinetics. No evidence that these should be used routinely in babies. Lots of concerns that they could be harmful. I personally would never use erythromycin, or if it was available, cisapride. We used to use cisapride a lot. Since we were stopped from using it, we've still managed okay. Question about rotation, I'm not quite sure. Routinely adding human milk fortifier, yes, we routinely start once the babies have reached full feeds and been on full feeds for 24 hours. Gravity feeding or continuous, I think gravity feeding is a great idea. To me, this would be the perfect solution. I would actually, if I could persuade my nurses, I would gravity feed milk every 1 hour. Because the milk can come up and down the tube a little bit as the baby gets used to it, and you see some of it bubbling back up and some of it going down. And I think 1 hourly in many ways would actually be the most physiological. There's nothing physiological about 3 hourly feeds in a 25-weeker. The gut simply wasn't designed for that, but miraculously it seems to work. So I don't really like continuous feeds, but it's the only thing that my nurses would agree to at the minute. And we all know that if you upset your nurses, then you're going to pay.
You're in trouble.
So I keep quiet. But yes, I think if I had my way, I would gravity feed every 1 hour in babies over the first week or two. Home modified cow milk, I would be very careful about using anything like that. The protein and the sodium content of cow's milk is totally inadequate for even term babies. It's better than water possibly, but I would be very careful. Oropharyngeal colostrum for babies treated conservatively for neck. What I would do is the first 2 days after surgery, I wouldn't be thinking about it, but after that, I would be using mother's milk for mouth care for that baby's mouth, and undoubtedly small amounts will be swallowed. Remember that even if you put a baby nil by mouth, he's producing lots of gastric secretions the whole time. And honestly, 0.5 mils of breast milk that trickles down to the stomach is not going to give that baby a second episode of neck. So I think it's absolutely fine to give small amounts. Do you think that's enough? I'll stop there for a bit and then see if there's any questions that you guys want to ask.
Wow, that was a nice, quick run through of those questions, Nick. I'm totally impressed. Are there any other comments, questions from the discussants?
Nick, I have one just real quickly. You spent some time on counseling the expectant mother of a preterm delivered baby about mother's milk and so forth, as well as all of the other medical things that go on. My experience has been that this is a much more difficult conversation to have than you implied, because most of the time preterm delivery is sudden, urgent. There may be some significant distress going on in the mother and her family and friends that are with her. Obstetricians don't do this because that implies that they're going to induce fear of preterm delivery, so they don't talk about these things. So it just seems a lot more complicated than you express, and I'm delighted that you've been successful. Maybe you could expand a bit on that.
Yeah, like, honestly, I think these are things that become a bit easier the older you get in a way. I 20 years ago, I was explaining the in and outs of every neonatal pathology that babies could get when I was speaking to these mothers on the antenatal ward or in fetal medicine clinic. And I've come to realize that this information goes in one ear and out the other. They're so stressed and anxious about what's going on that it's actually quite difficult to get very much information over. The majority of the times there aren't any decisions to be made. The baby's going to be delivered or it's going to just arrive. We're going to have to get on and treat it the best we can. But there is good data to show that an antenatal conversation with a doctor carries a huge impact on that mother's decision to breastfeed. And even though most of my residents and fellows know far less about breastfeeding than the nurses or the midwives, the fact is, if you turn up with the name doctor, the parents believe you. And therefore, I think we do have a duty to advocate what is best for the baby. I don't generally think parents should be given this choice between what they want to do. If I was a parent and I knew nothing about it, I would want you as the doctor to come along and tell me what was best and how you're going to help me to do the best thing. So it is about learning a set of phrases that work for you. I mean, what works for me won't work in other contexts and other situations. But I do think that antenatally, we don't need to tell people what the percentage chance of ROP or BPD or NEC is. I mean, like, that information doesn't really help the parents. The parents want to know what's going to make a difference to their baby. And the one thing we know at the minute that makes a difference to all of those diseases is getting mum's breast milk into the baby. And so if you've got just 3 minutes, I would spend 2.5 minutes telling them that everything's going to be all right and you're going to help them do the best thing for their baby.
Yeah. And I think it's difficult, it's a stressful situation, but the end, I mean, if a doctor shows up with the mother, sometimes a few words will also help calm down the mother, put things in perspective. So I strongly support this, and we try very hard to achieve that. It's not always easy.
But parents want to be reassured, and I'm not suggesting we become completely paternalistic, but I think in the last 10 or 20 years, this idea that you should have informed consent, that you should know about all these terrible things that are going to happen to your baby, I really don't think that helps. If it was me and I wasn't a medic, I would want the doctor to come along and metaphorically put their arm around my shoulder, tell me I'm going to help do the best thing for your baby. The one thing that you can do now is, let me just explain to you how we're going to help you get some breast milk from you. It doesn't matter how much we get, even one drop is going to make a difference. That conversation is really important, and it's really important when it's done by a doctor and not left to a dietitian or some other person. I'm not saying they don't know more about it than we do, but when you turn up and you say, I'm a doctor and this is the best thing, it has a huge impact on what parents do.
I think it's really important that you give the parents, especially the mother, something that she can do herself that will help her baby. Let the doctors take care of the rest of the issues. And I think that focus on giving the mother something positive that she can do to help her baby, because she's very afraid that she is causing this baby's preterm delivery. And this gives her something to counter that fear. I think that's a very good point.
Well, I see a lot of people, a lot of doctors spending all their lives getting these echo machines out and ultrasounding the blood flow in the superior mesenteric. I mean, like, it's great fun and it looks very, very clever, but actually it doesn't really make any difference to the baby most of the time. And they don't spend enough time doing the really simple basic stuff, which is saying, look, breast milk's really important, because we kind of think, well, that's not for us to do as doctors. It is. That's why I say I emphasize this concept of nutrition. Doing good nutrition is not simply working out how much protein or sodium to give a baby. It's actually thinking about the holistic concept of how you're going to nourish that baby, including all those different aspects.
So I think we're going to have to wind up for now, and I want to thank Nick for his wonderful presentation. Outstanding. Really enjoyed it. And also Flavia, Virgilio, Bill for their participation and discussions, and also all the participants who were involved with this. Tomorrow, we will have Dr. Tom Jaksic as our lecturer, and he will be talking about nutritional issues surrounding babies with surgical problems. So I look forward to seeing